Hi everyone and welcome to Dynamic Simulation. My name is Sean Segrin and I am an emergency physician as well as the founder and director of Dynamic Simulation. Really excited that you're here today, and we're really excited to be doing a sim session for your group. Before your session, we just wanted to spend a few moments discussing something that is critically important and probably the most important thing that we are going to discuss and practice during the sim session. It's this concept called Crisis Resource Management, or CRM. So CRM is really a set of team behaviors that helps clinical teams function clearly, calmly, and effectively when tasks or the situation is really complex, time-sensitive, or chaotic. So there's a lot of concepts that we could talk about as far as CRM goes. Things like cognitive aids, role clarity, managing tone, anticipating the plan. All of those things matter. But if we want you to remember one core idea from today, it is this. It's that elite clinical teams build and protect a shared mental model. So what does that mean? It really means that the team understands three things: where we were, where we are now, and where we are going next. In a crisis, the team can lose that shared understanding very quickly. The patient changes, the plan changes, people enter the room, they leave the room, meds are prepared, and they're given, and new information arrives, and then old information becomes less relevant. The room can move faster than the team's ability to stay connected. And that is where CRM comes in. CRM is how we keep the team connected to the same clinical picture. It is how we make the invisible visible. We say the plan out loud and we assign roles. We summarize out loud, we ask for help out loud. To be clear is to be kind. At Dynamic Simulation, we really want you to think about CRM as a layered model, a so-called bubble. Elite teams function inside a bubble of what is known as psychological safety. So that means that people can feel that they can speak up, they can ask questions, they can clarify uncertainty, and they can raise concerns. It also means that a nurse can say things like, "I'm worried about the blood pressure." It means that a respiratory therapist can say, "I don't think that the ventilation strategy is working." It means a learner can even say, "Can we pause and clarify the plan?" So psychological safety doesn't really mean that the room becomes casual. It just means that it does not mean that leadership becomes vague. In a crisis, leadership still needs to be clear, directed, and organized. But what it really means is that the team can speak honestly while still moving with urgency. The leader will never see everything, and the team is their safety net. Inside the bubble of psychological safety is the shared mental model. This is the main driver of team performance. The team needs to understand what is happening, what the priorities are, what the plan is, who is doing what, and what we are worried about next. The shared mental model is a thing that we are constantly trying to build, protect, and update. The three main behaviors that help us do this are role delegation, closed loop communication, and team summaries. I'm going to talk about each one of those. So the first behavior is role delegation. I think all of us can agree that the most chaotic part of a resuscitation is usually at the beginning of the case, or when the moment when the patient begins to crash. So those are the moments where role delegation is most important. At the beginning, people often rush toward the patient and start doing tasks. Everybody just wants to help. The problem is that without role clarity, the room can become crowded and disorganized very quickly. A team needs to know who is leading, who is managing the airway, who's managing meds, who's documenting, who's watching the monitor, getting equipment, calling for help, etc. Clear roles are going to reduce noise and they reduce duplication. They give people a place to stand and a job to do. They also help the team move from chaos into structure. One of the most important concepts, though, that I want to make sure is clear is that role delegation does not need to be rigid forever. Many of the sites that we work with are extremely resource limited. Teams may not have enough people to assign every role perfectly. People may need to cover multiple jobs. Roles may need to change as the situation evolves, and that is completely okay and completely real. The goal is not perfect role assignment, but what it is it's giving us enough clarity to get through the most chaotic parts of the resuscitation. Again, at the beginning, just before or when the patient arrives, or when they become worse or they become unstable. Once the team has stabilized, roles can become more flexible. The leader can reassign people, the team members can adapt. But again, at the beginning, during a major deterioration, clear role delegation helps create the first version of that shared mental model. The second behavior is closed loop communication. Such a buzzword. What is it really? In a loud clinical environment, there's a major difference between saying something and knowing what was heard, understood, still wanted, and then completed. This is especially important with medications. Closed loop communication has several steps. First, the instruction should be directed to a specific person. So if I'm the physician, I may say, Jamie, could you please prepare 1 milligram of epinephrine? Second, the receiver then repeats it back, preparing 1 milligram of epinephrine. Third, before the medication is given, the receiver confirms that the medication is prepared and that the team leader still wants it administered. Sean, 1 milligram of epinephrine is prepared. Do you still want me to give it? The leader would then confirm, yes, give it now. And then lastly, once the medication has been administered, the receiver announces it clearly to the group. Epinephrine is in, loud and proud. The team needs to hear when a critical action is complete. The leader needs to hear it, the documenter or the recorder needs to hear it, and the team needs to update its shared mental model. This same principle applies beyond medication. If someone is asked to call the ICU, get blood, apply pads, start fluids, prepare for intubations, or bring equipment, the loop is complete when the team knows that the task has been done. Closed loop communication is difficult to get right every time. It does not need to be perfect. It's also going to feel slower at first, but when you practice it, it prevents missed tasks, duplicated tasks, medication errors, and false assumptions. The third behavior is team summaries. Team summaries are one of the most powerful tools in a crisis leadership. A team summary asks 3 questions. Where were we? Where are we now? And what are we going to do next? It can sound something like this. All quiet in the room, please. This is a 68-year-old male with septic shock. Airway is being maintained right now with high flow nasal cannula. Blood pressure remains low despite fluid. Norepinephrine is running at 5 micrograms per minute. Antibiotics are in. Our priorities are to secure the airway with intubation. Could you please tell me when the intubation drugs are ready? In a crisis, the room can become loud very quickly. People talk over each other. Side conversations develop, emotions rise. The team starts moving in multiple directions. And a clear team summary brings the room back together. It contains the energy in the room and it lowers the emotional temperature. This does not need to be done only by the physician. Someone else in that room can also summarize if they feel comfortable and have enough information at hand. One of the most important people in that room is the documenter or the recorder. They hold the strings from the beginning of the case to the very end. So if you don't know what's going on in the resuscitation, it's loud, it's chaotic, ask for a summary. You might be the one to do it, or you might ask the documenter, the recorder, or even the team leader to please provide one. Surrounding all of this is tone. The leader is often the loudest emotional signal in the room. Emotional contagion is very real. The team does not only hear the leader's words, they feel the leader's tone. If the leader sounds panicked or rushed, irritated or dismissive, that emotion spreads through the room. People become quieter, they hesitate, and then they stop asking questions, they focus on avoiding criticism, and that shared mental model and psychological safety starts to break down. If the leader is calm, clear, and firm, that also spreads. A calm voice helps regulate the room. It helps organize the team. Calm does not mean slow, and calm does not mean passive. It just means controlled. You can actively manage your tone. Take one breath before the next order. Lower your voice slightly. Use names as much as possible. Make eye contact. Say what you're worried about. Invite the team in. You might say something like, team, I'm concerned that this patient is deteriorating. I need everyone to stay in role. If you see something I'm missing, please let me know and say it out loud. That one sentence does so many things. It names a concern. It keeps the team organized. It reinforces role clarity. and invites people to speak up, it protects the shared mental model. There are other CRM behaviors that we're going to talk about as well. We're going to talk about things like using cognitive aids, calling for help early, knowing your environment. These are all very important. They help the team stay connected to the shared mental model. During our simulation, we're going to keep coming back to 3 core behaviors: role delegation, closed loop communication, team summaries. Use role delegation to create structure when the room is chaotic. Use closed loop communication to make sure critical information and tasks are heard, confirmed, and completed. Use team summaries to quiet the room, update the plan, invite other ideas, and help the team anticipate what is coming next. All of this happens inside a bubble of psychological safety. People need to feel like they're able to speak, to clarify, and to raise concerns. That is how teams stay clear under immense pressure. That's how teams move together, and that's how teams create enough calm to keep thinking. The goal during your sim is not perfection. It is practice. We want you to notice what actually happens in the room. How do we communicate? How do we assign roles? How do we close the loop, summarize, and manage tone? How do we create enough psychological safety for the team to function? When the room gets chaotic, the strongest teams are the teams that can stay clear together. They know where they were, they know where they are, and they know what is coming next. They communicate that clearly, and they give the patient the best chance possible.